Otalgia is defined as ear pain. Otalgia may occur in isolation or along with discharge or hearing loss. Ear pain may occur from a process within the ear itself or may be referred to the ear from a nearby source. Two separate and distinct types of otalgia exist. Pain that originates within the ear is primary otalgia, whereas pain that originates outside the ear is referred otalgia. Pain from the ear itself may result from a pressure gradient between the middle ear and the outside ear from local inflammation or both. A middle ear pressure gradient usually involves eustachian tube obstruction, which inhibits equilibration between middle ear pressure and the atmospheric pressure, and also allows fluid to accumulate in the middle ear. Otitis media causes painful inflammation of the tympanic membrane, as well as pain from increased middle ear pressure, which causes bulging of tympanic membrane. Referred pain can result from disorder in areas innervated by cranial nerves responsible for sensation in the external and the middle ear, 5th, 9th, and the 10th nerve. Specific areas include the nose, paranasal sinus, nasopharynx, teeth, gingiva, temporomandibular joint, mandible, parotid glands, tongue, palatal tonsil, pharynx, larynx, trachea, and esophagus. Disorder in this area sometimes also obstruct the eustachian tube, causing pain due to a middle ear pressure gradient. Isolated ear pain is a common manifestation of migraine. More than 2/3 of patients presenting to a specialty ear clinic with ear pain and a normal ear examination meet diagnostic criteria for migraine headache. So, in established migraine headache, we should have to check for ear pain sign. In this case, ear pain improves when migraines are treated. Otalgia results from otalgic causes or from non-otalgic causes referred to the ear from nearby disease process. So, with acute pain, the most common causes are middle ear effusion with or without infection, external ear infection. With chronic pain greater than 2 to 3 weeks, the most common causes are temporomandibular joint dysfunction, eustachian tube dysfunction, chronic otitis media, and externa, and also migraine. Also, with chronic pain, a tumor must be considered, particularly in older patients, and if the pain is associated with ear drainage or any bleeding from the ear canal. People with diabetes or chronic kidney disease or in other immunocompromised state may develop a particularly severe form of otitis externa called necrotizing otitis externa, previously called malignant otitis externa. In this situation, if abnormal soft tissue is found on examination of ear canal, the tissue must be biopsied to exclude malignancy. Temporomandibular joint dysfunction and migraine are common causes of otalgia in patients with a normal ear examination. When we evaluate a patient with otalgia, history of present illness should assess the location, duration, and the severity of ear pain, and whether it is constant or intermittent. If intermittent, it's important to determine whether pain is random or occurs mainly with swallowing or jaw movement. Important associated symptoms include ear drainage, hearing loss, or sore throat. The patient should be asked about any attempt at cleaning the ear canal with cotton swab and the like, or other recent instrumentation, foreign bodies, recent air travel or scuba diving, and swimming or other recurrent water exposure to ears. Review of system should ask about symptoms of chronic illness such as weight loss and fever. Past medical history should ask about non-diabetes or other immunocompromised state, previous ear disorder, and amount and the duration of tobacco and alcohol use. Patients should also be asked about previous otalgic history, previous ear discharge, hearing loss, tinnitus, and otalgic surgery, such as tympanostomy tubes during childhood. On physical examination, the examination focuses on the ear, nose, and the throat, and also check for fever. The pinna and the area over the mastoid process should be inspected for redness and swelling. The pinna is gently tugged, and the significant pain exacerbation with tugging suggests otitis externa. The ear canal should be examined for redness, discharge, swelling, cerumen or foreign body, and any other lesion. The tympanic membrane should be examined for redness, perforation, and signs of middle ear infection, such as bulging and distortion. In addition, a bedside test of hearing should be conducted, including the Weber and Raynaud test, using tuning fork. The throat should be examined for erythema, tonsillar exudate, peritonsillar swelling, and any mucosal lesion suggesting malignancy. Temporomandibular joint function should be assessed by palpation of the joint on opening and the closing of the mouth, and a notification should be made of trismus or evidence of bruxism, such as wearing down of teeth. The neck should be palpated for lymphadenopathy. In office, fiber-optic examination of the pharynx and the larynx should be considered, particularly if no cause for the pain is identified on routine examination, and if non-otalgic symptoms such as hoarseness, difficult swallowing, or nasal obstruction are reported. The following findings are of particular concern: diabetes or immunocompromised state or CKD, redness and fluctuance over mastoid and the protrusion of auricle, severe swelling at external auditory canal meatus, chronic pain especially if associated with other head and neck symptoms, and pain that wakes the patient from sleep. An important differentiator is whether the ear examination is normal, middle and external ear disorder cause abnormal physical finding, which when combined with strain usually suggest otogenic etiology. For example, patient with chronic eustachian tooth dysfunction of abnormality of tympanic membrane, typically a retraction pocket. Patient with normal ear examination may have visible oropharyngeal cause such as tonsillitis or peritonsillar abscess. Ear pain due to neuralgia such as trigeminal neuralgia, much less commonly glossopharyngeal neuralgia has a classic manifestation as a brief episode of extreme severe sharp pain. Chronic ear pain without abnormality on ear examination may be due to TMJ disorder or migraine, but patients should have a thorough head and neck examination, including fiber optic examination to exclude cancer. When we came to treatment, pain is treated with oral analgesics, usually non-steroidal anti-inflammatory drugs or acetaminophen, but sometimes a brief course of oral opioids is necessary, particularly for severe case of severe otitis externa. In case of severe otitis externa, effective treatment requires suctioning of debris from the ear canal and the insertion of wick to allow for delivery of antibiotic ear drops to the infected tissue. Oral antibiotics are not used unless part of or all of pinna is erythematous, suggesting speed of infection. Oral antibiotics also may be used for patients who are immunocompromised. Topical analgesics are generally not very effective and are not routinely recommended. Patients should be instructed to avoid digging in the ears with any object, no matter how soft the objects are or how careful patients claim to be. Patients with otitis externa should keep their ears dry. Also, patients should not irrigate their ears unless instructed by a physician to do so, and then only gently. An oral irrigator should never be used to irrigate the ear.